So I'm Maureen, Dr. Maureen Nash. I'm an internal medicine physician and a psychiatrist. I've worked full-time in geriatrics since I finished residency. As an engineer, and then I went to medical school at the University of Kansas, and then I did a 5-year residency in internal medicine and psychiatry up at Dartmouth, which is in New England. And I've been in Oregon since 2005. For the first 10 years or so, I worked at the Tuality Center for Geriatric Psychiatry and finished up as the medical director there. A couple years ago, I moved over to Providence ElderPlace, which is a PACE program, a program of all-inclusive care for the elderly. And we have 10 clinics and day and social centers for older adults who meet criteria for our program. So I was invited here today to talk a little bit about delirium, dementia, what is Alzheimer's disease, how do you tell them apart, what do you do when you find them? So hopefully by the end of this presentation, you will be able to sort of describe what they are, give an overview of how one might find out whether someone has one of those illnesses, and have an idea about a basic treatment strategy. So I want to just start with how many people in the room work at a assisted living or care facility or adult foster home? Excellent. How many people in the room have social work or LPC or counseling, psychology type? Not that those things are all the same. Okay. And how many people, nurses, and anybody who's a prescriber? Okay, excellent. So the presentation is probably a little overly heavy on the prescribing information. So I'm going to do sort of the airplane view of those slides, but I'm happy to answer any questions during the breaks. And the handouts have a lot of information really about pharmacological interventions. And the reason that is because there's not a lot of evidence for treatments outside of the pharmacological. There's a lot of sort of theories and various things put out there in very small studies, most of which have some real challenges evidence-wise. But and just a little bit about why do you even want to listen to me? So I am on the Council on Geriatric Psychiatry of the American Psychiatric Association, and so this is my area of specialty. So I've really been working nearly full-time in the dementia delirium world since about 2000 or so. So I don't have any financial disclosures to make. I don't take money from anyone that I might be talking about today. I will be talking about off-label treatments. Off-label means treating something with a medicine that isn't FDA approved to treat that illness. We have a system in the United States where medications are FDA approved to treat an illness, even though for most things outside of oncology, medications treat sort of symptoms or body systems or pathways of various sorts in the brain. And medicines don't really exactly treat illnesses, but that's how we do FDA approval. So, and sometimes people misunderstand that and they think off-label means you shouldn't do it. And what I would say is, if there's evidence for it, then you might want to consider it. If there's no evidence, then you might not want to consider it. So I want to start just overall with a little disclaimer. So most people, when they think about dementia or they think about Alzheimer's disease, they think of it as a cognitive illness. And I think that's probably because psychologists and physicians, when they are over-attached, we're over-attached to our brains and our cognition. And so we sort of look at the world through that lens. Whereas I would like to posit that dementia and Alzheimer's disease in particular are actually behavioral illnesses. And why would you say that, Dr. Nash? Well, Frau A, who is Dr. Alzheimer's first patient, and here's a picture of her, developed Alzheimer's disease in her mid-40s, died at age 56. This is an actual picture of her when she was younger than 56. And Dr. Alzheimer met her because she was delusional, she was hallucinating, she couldn't function anymore, and she was a danger to her children and herself, right? So all of those, none of that is because her memory wasn't working. Now, her memory wasn't working, but that wasn't the issue that brought her to medical attention. So when we look at a confused older adult, the only answers for why a person is confused are not delirium or dementia, but they are by far the most common reasons, assuming we're not talking about someone who may have been confused like their whole life. So those folks are in a different category. So delirium often has a rapid onset, and it involves a disturbance of consciousness, awareness, and attention. Dementia involves multiple cognitive and neurological deficits in various parts of brain functioning, and it is almost always, in all the main causes of it, slowly progressive over time. So, and the DSM-5, the Diagnostic and Statistical Manual of the American Psychiatric Association, they reconceptualized everything and sort of turned the world upside down and put new labels on things, but they still have delirium. And then they have these two new categories, mild neurocognitive disorder and major neurocognitive disorder. Just for the record, when people say major neurocognitive disorder, which if you're lucky isn't often, what they really are talking about is dementia, right? So that's what the neurologists and the internists, we're all going to still be talking about dementia. But this was mostly set up to help researchers, in my opinion. So what I want to tell you is that differentiating delirium from dementia isn't straightforward, but if you have a path to follow, it's not rocket science. And time course of the symptoms and the onset is quite important in the diagnosis. And then just to make it more confusing, who is most likely to be delirious? Anybody who has structural damage to their brain. So somebody who's had a TBI, somebody who has a pre-existing dementia. So you can have both, right? So they're not mutually exclusive. So why do you care? Why do you care about delirium? Well, I would like you to care quite a bit, actually. But let me start with what are the challenges with the literature, if you want to say, well, what's the evidence about things to do with delirium? Well, the challenge is that there are only small studies. It's quite difficult to get informed consent for a study from someone who doesn't know where they are or what's going on around them. Most studies that do exist are either like they take place in one hospital, or if you're lucky, maybe a hospital system, or they're single specialty. So they're like after a hip fracture or after cardiac surgery or with pneumonia. The threshold for diagnosing delirium varies from person to person, and if you just take a snapshot of a person and their behaviors and have no other information than just your 5-minute interaction if you're a physician and your 7.5-minute interaction if you're a nurse, if you just take that, you actually can't tell whether somebody has delirium or dementia. So just that snapshot is very important, gives you lots of information, but it doesn't help you make a definitive diagnosis. You actually have to have lots of other information. So why do you care? Well, people who become delirious are at severe risk of becoming demented. And who in this room knows somebody who has dementia? Right. Who in this room is hoping that when they grow up, that's what they have? Right. So delirium predicts dementia. It at least doubles the risk. But that's an association. There's actually not good evidence that it's a causality. So it's quite possible that people who become delirious, there's something about some of them, and they actually either have the beginnings of dementia or they have cognitive changes that later turn out to be a dementia. People who become delirious in the ICU are at high risk of death, 10% higher risk of death for each day that they're delirious. Mortality. This followed a group of older adults, 65 and older, for 3 months, people who'd become delirious. 16% without delirium died over the next 3 months, whereas 35% or 34% died who became delirious. So again, this is an association. It may be causal. It may, people may have died because of their delirium or whatever was causing their delirium. But there's another choice, which is, delirium could be a marker for nearing the end of life. And a lot of people are sort of conceptualizing delirium as acute brain failure, whereas dementia is kind of chronic brain failure. And I think there's some merit to looking at it that way. Here is one of those studies that is a single institution. It's a skilled nursing facility. But this is arguably the most important slide. It was actually a very well done study. It was pretty small, though, about 400 people. And what they found was the people who entered the skilled nursing facility, if their delirium was recognized, treated, and resolved in less than 2 weeks, they regained 100% of their pre-hospital level of functioning. 100%, which if you're 80 is a big deal. People who did not resolve their delirium in 2 weeks or less only regained 50%. So they had a permanent functional loss. So this is why I want you to care about it. This is why I want you to look for it. When you find it, I want you to aggressively treat it and pay attention to it, because it really does matter. And sort of this study happens to also pass the smell test, right? This matches my clinical experience. This matches what I've seen in the 18,000 or so people that I've treated. So if you ever want to get a lot of emotion going, if you're in a group of physicians, I can tell you, you want to talk about UTIs. I mean, the affect is amazing. People start to cry, they tear their hair out. And I think a lot of it has to do with what chair you sit in, as with many things in life. Because you don't want to treat an asymptomatic UTI, because usually what that means is this is somebody who has bacteria in their urine for whatever reason, but they don't have an infection. It's actually not that uncommon to have some bacteria living in your bladder that shows up in your urine but isn't causing you an infection. So what you want to do is treat symptomatic UTIs, and there's the challenge. Because when you're in an emergency room person, an emergency department nurse or physician, what you really care about is urosepsis, right? If their blood pressure is crashing and you need to fix them right away and get them sent to the unit, the ICU, well, that's what they care about. And otherwise, they're a little nonplussed. The internal medicine physician, one of which I am, they want to know, is the white count elevated? So they want to look at the lab work. Do they have a fever? Do they have pain in their lower back? Or do they have pain or burning with urination? Those are the symptoms that they ask about, and those are the signs they look for. And then the psychiatrist actually wants to know about acute behavior change. So you can see what is a symptom is not as simple a question as it sounds. So I want to tell you a little bit about Grace. Grace is more or less somebody I met in upstate New York before I came to Oregon. She was a lady who lived in a nursing home because they didn't have other levels of care. She probably wouldn't have lived in a nursing home if she was here in Oregon. She probably would have lived at an adult foster home or maybe a residential care facility. She had cognitive impairment, but not dementia. She sat in a wheelchair. She didn't ambulate, but she sort of paddled herself around the place. Not that uncommon of a situation. So she started sort of out of the blue, literally running herself into walls, running people over at the nursing home. And this was a drastic change from Grace, who normally was, a kind of pleasant person. She came to my hospital in upstate New York. We found that she had a urinary tract infection. We found that there were lots of things about her med list that could be improved for an 88-year-old person. Getting rid of benzodiazepines, lowering the anticholinergic medications. So we did all those things. She got better in about a week. We sent her back to the nursing home. A month later, they called and said, she was great when she first came back, but now she's having the same problem. And she's like screaming hysterically much of the time. And they said, she has anxiety and you need to treat her anxiety. So they sent her back. So this second time, we checked her urine, and lo and behold, she had a UTI again. The only thing we did this second time was put it on an antibiotic, which is not the normal treatment for most psychiatric illnesses. And as far as I know, doesn't actually treat anxiety. But she got better. We sent her back to the nursing home. So about 2 months later, they called me again. And they said, she was great when she came back, but she's having the same problem. And I said, check her urine. I think she has a UTI. And I think she has recurrent UTIs, and you need to find out why, if you can, and fix that problem. And they had a big argument with me. They didn't want to do it. They kept saying, this is psychiatric, it's behavioral. And I was like, it's behavioral, but it's not psychiatric. And I'm not taking her on my psychiatric unit until you fix her UTI. And I never heard about Grace ever again. And this is really a classic case of delirium. And this was actually not too soon before I moved to Oregon. So Bill is somebody who I heard about when I moved to Oregon. It was actually the very first time I was on call. And I got a call from an emergency room who said, we've got this really advanced person, advanced dementia. He's got an abnormal UA, but I don't think it's a UTI, the emergency room person told me. He assaulted 2 caregivers. That's how he ended up in the ED. He didn't have a fever. He had normal CBC. They couldn't find anything wrong with him. You need to take him on your psych unit. And, remembering Grace, I said, no, I'm not going to take him on the psych unit unless you treat his UTI first. And the ED doctor was quite upset with me. She yelled at me. She said, he doesn't have a UTI. She hung up on the phone. Matter of fact, the next day she called my boss to complain about me. But they did keep him in the ED because that's how we do things in Oregon. And then they treated him with levofloxacin, which is an antibiotic that covers many urinary tract infections. He didn't change. He was still aggressive. And 3 days later, we took him on our unit. And this is actually a quite classic case of dementia with behavior disturbance. And so these are actually really classic cases that are kind of textbook and easy to figure out. Unfortunately, that's not really how patients and people show up in our office. They don't come wrapped in neat packages. But that's the package you're looking for. And that's how you want to look at it. You want to look for the history. You want to look for, what's the time course of things happening. Because it turned out, Bill didn't suddenly just assault 2 people out of the blue. He'd actually been having increasing behaviors over time. But the ED staff didn't have time or energy to get any of that history. So there was history there that would have been helpful to have. So the key deficit, the way the DSM is organized, every illness is conceptualized as having a key deficit and then other things associated with it. And the key deficit in delirium is an attentional impairment. Attention is impaired and accompanied by a lack of awareness of the environment. You also have to have other cognitive problems. Hallucinations are pretty common. Language disturbance is pretty common. Sleep-wake cycle being disrupted is extremely common and frankly almost always there, at least at some point during the delirium. And then there's this sort of sundowners thing that people talk about, which is where later in the day people tend to have worsened behavioral problems. It tends to happen in the late afternoon when people are more fatigued. So when you look and if you read about delirium, people talk about this hyperactive delirium where people are hyperactive and a hypoactive delirium where people are sort of just laying around. From a medical point of view, the people with hypoactive delirium are often not recognized because they're not causing you any problems. They don't ask you questions. They don't interrupt you. They don't complain. They just kind of lay there. And unfortunately, in some places, that's actually a good thing. The most common kind of delirious state really is a mixed one. But the message I want you to take is these are great adjectives. They can be helpful, but they have no evidence that you should treat somebody differently. If somebody has a hypoactive delirium, you should treat them the same way you treat a hyperactive delirium. And that's what I want you to take away from that. So abrupt onset, within about 3 days, you get the full-fledged thing. It can lead to coma and death, and in a substantial minority of people it does. It can also linger in this subacute and chronic phase for weeks or months. And the VA has a very nice toolkit, and I have the web address in the slide set. They looked at sort of what are things that make you more likely to have delirium: visual impairment, infection, being over 65, being really ill, Apache score. Being over 80 increases your risk by over 5 times. Not everybody who's over 80 has delirium, but they're certainly at risk of it. Cognitive impairment and a fracture on admission. Do you think fractures cause delirium? Well, I would say delirium could certainly cause falls because people are confused and not able to attend. So it's one of those, these are all associations, so you can't really say that they're causality. Age is an independent and a major part of the risk factor, as earlier stated. And as you can see, once you hit 70, the risk goes way, way up in people who are in the hospital. This was particularly data from an ICU. But this is a very similar graph to people who have Alzheimer's disease. So if you want to look at age and the risk of Alzheimer's disease, it actually comes up and then it sort of goes like this. So it's very similar. And so age is a big deal, but not everybody who's old gets dementia, not everybody who's old gets Alzheimer's, and not everybody who's old has a delirium. Lorazepam or Ativan, benzodiazepines are independent risk factors for delirium. And why might that be? Well, among other things, the single thing that benzodiazepines do first is impair your ability to attend. They sit on the same receptors in the brain as alcohol. How many people want to give grandma, 5 drinks? Well, don't give her 2 or 3 tabs of lorazepam if you don't want to give her 5 drinks of alcohol, because that's really what you're doing. It's quite common in inpatients. It's quite common in people who live in nursing homes. So in Oregon, that would translate to lots of different care facilities, because people in Oregon live at many levels of care, and in other states, they would be stuck in nursing homes. Almost everybody who has a terminal illness becomes delirious at some point. There's lots of causes of it. Sort of the shorthand is if you're not getting enough oxygen, you're not getting enough glucose, or you're getting way too much glucose. If you're having a problem getting blood from vascular disease, or your heart isn't pumping blood, which is how oxygen and glucose get to places in your brain. There's some unusual ones that people don't always think about, and that's urinary retention and fecal impaction. Anybody who works with older adults knows that having regular bowel movements is something that people care about, and we should care too. That's my message. We should care too. I care that you are not constipated. And among other things, I care because if you are and you get a fecal impaction, you're very likely to get delirious. And that leads to middle of the night phone calls. And who wants that? Certainly not the person who's being called about. What causes it? There's lots of different things that have been shown to be abnormal in the brains of people who are delirious. Dopamine excess is pretty commonly seen, though not always. Acetylcholine, which is a neurotransmitter that helps with attention, there's often not enough of it. And melatonin is sort of the newest kid on the block, the kind of sexy new molecule for delirium. And there's a lot of people who have delirium don't quite have enough of that either. This is sort of a picture that shows, so the dark gray are the basically acetylcholine, cholinergic places in the brain. And then you sort of see the lighter colored things are areas that are abnormal in a certain subset of people with delirium. And there's some overlap there. You can see that a lot of these pathways travel through and around and near. There's many, many theories. I'm going to show you 3 slides. There's a great article from 2013 in the American Journal of Geriatric Psychiatry about delirium. If you really want technical information, I recommend this. But I have a couple slides in here because I always get complaints because I don't have enough pictures in my slides. I also get complaints that I talk fast, so I apologize. Blood-brain barrier inflammation. So inflammation leading to blood-brain barrier not acting right is associated with delirium in many people. It's not probably true in everybody who has delirium, but there's a huge number of people that it is. And our blood-brain barrier is the thing that protects our brain from most things that we breathe, eat, drink, or absorb through our skin. So those things can easily affect our heart, our kidneys, our lungs, but it's quite difficult for those things to affect our brain in general because we have a blood-brain barrier that's working well. But if we have an inflammatory condition for one reason or another, it works less well. And again, sort of one theory is, cerebral ischemia, or the brain not getting enough blood, oxygen, glucose, leads to delirium. And this is sort of one. And then there's a common theory as well. This is really caused by some sort of endocrine, hypothalamus, pituitary, and all the feedback loops that have to do with that. The fight or flight. If you have ever seen somebody with a hyperactive delirium, they look like they're frightened that somebody's going to attack them, and in fact may believe somebody's going to attack them. So this sort of is the theory about this. But this is from that same article, and this is my evidence that delirium is not well understood. So I used to be an engineer, and we do a lot of flow charts and diagrams in engineering to explain things. But what I can tell you is there's lots of theories, and my personal opinion is your delirium and my delirium may be caused by different things. And we're just way far away from being able to figure out what's causing specifically your delirium. Lots of things can lead to a delirious state. It turns out there's a lot of treatments that help with delirium. And fortunately, at this point, the treatments that we know about don't depend on knowing what actually delirium totally is. So before you treat it, though, you have to find it. So the gold standard is the confusion assessment method. It was designed by Sharon Inouye and her group, which was at Yale and is now at Harvard, or vice versa. It's a great tool, but it's sort of an academic kind of tool. It's not great for on a nursing unit. It's not great for sort of lots of different levels of training. So practically, I'm not a big fan of it. Now the VA has a modified RAS score, and that's how they do it. And I like this better because it has pictures. So even though I don't have a lot of pictures on my slides, I do like pictures. And you can sort of look at this, and they tell you how to get it. And this is in the Delirium Toolbox. So you want to observe the patient. If they're not alert, you want to ask them to describe how they're feeling. Notice that that's not a yes or no question. Yes or no questions are the enemy of diagnosis, really in all fields. And then you score it from that. There's another bedside test, and this is actually my favorite. Months of the year backwards in older adults, if people can do months of the year forward, so you have to make sure that they can do that first, then you ask them to list out the months of the year backwards. And that's a great screening tool for delirium because you really have to attend or pay attention and have some ability to focus to do months of the year backwards. If you have a younger person, you want to do months of the year backwards, and you want to do what they call spatial span forward, which means give people 5 random digits and ask them to repeat them like a minute or so after you tell them. So basically, this I like because it's sort of easy to remember, kind of catchy, months of the year backwards, and really anybody can do it. And the other thing that's kind of nice about it is if people speak a different language, as long as it's sort of a Romance language, or if it's a language that has 12 months in it, you can use this in any language. And you can also use, everybody has numbers, right, in their language. So, can you prevent or decrease the risk? This is the most important slide here on prevention of delirium. If you can help manage these 6 things are really important. Sleep deprivation, cognitive impairment. Oh, well, I can't fix somebody's cognitive impairment. No, but if somebody has cognitive impairment, you can try and compensate for it. So if somebody is slightly confused, which many sick people are, you can reorient them frequently. Once you know somebody has a delirium, you really don't need to test them every day. Instead, what you really want to do is reassure them, right? So you want to tell them who you are, who they are, where they are, and what's going on. Just briefly. Hi, I'm Dr. Nash. You're Mary. You're here in the hospital at St. Charles, and you have been really sick because of a hip problem, and we're trying to help you. Really simple. It doesn't have to be complicated. But you start every single conversation like that. Why? Well, then they don't have to spend all their energy while you're talking trying to figure out who you are, who they are, and where they are and what's going on. You are letting them use what cognitive capacity they have to actually focus on themselves and the next questions that you ask them. Immobility is the enemy. Anybody who can walk should be walking. It is not normal to lay around in bed if you can walk. Now, obviously there are times when you can't walk, either because you're non-ambulatory or because you're having a particular problem, a bad case of heart failure or severe pneumonia or whatever. But when you are able to walk, it's important to do it. And if you can't walk, it's also important to do just things like sitting up, getting out of bed, getting back into bed. If people have visual impairment, you want to correct it as much as possible and pay attention to lighting. If people have hearing impairment, you can use those little amplifier boxes. If people don't have hearing aids, you can make sure the environment is as quiet as possible when you interact with them so that, again, they don't have to filter out all this other stuff. And finally, dehydration is a really important risk factor. And so encouraging people to drink, asking people frequently to drink, providing them whatever it is they like to drink within reason is really helpful. There's some evidence that antipsychotics might prevent delirium. That's really mostly been shown in cardiovascular surgeries. There's some evidence that giving people melatonin can prevent delirium. This was a study from up in Canada, and they just did 145 consecutively admitted people who were 65 and older, and they just gave them melatonin at bedtime for 14 days, people who were admitted to a hospital. And there actually was a pretty robust effect in decrease of delirium. And that's a pretty simple thing. Why might that work? Well, so one of the challenges with melatonin is it doesn't actually get through the blood-brain barrier. So I know it sells a lot in grocery stores and drugstores, but for those of us who have a functioning blood-brain barrier, it doesn't get through. But guess what? Many people who are delirious do not have a functioning blood-brain barrier. So it does get through. So it's going to be doing something a little bit different for that group of people than for the rest of us. Once you do find it, though, you want to treat it. This is a shameless plug for experts, and I would recommend you find somebody in your organization who can become an expert in delirium, because it's real common. You want to find it, treat it, prevent it. Prevent it, treat it if it happens. There's some evidence that using melatonin, this is a very new area of study. There's a group up at OHSU that is hot on the track of melatonin. And there's actually a drug company that has there's one medication out there that works on melatonin that's really expensive. And they actually published a study that had all of like 35 people in it, showing that their medicine actually helped decrease delirium and treat it when it occurred. And that by itself, I would say, is probably the best evidence, right? Because that means that they spent multi-millions of dollars to show that. So they actually really believe it's true. And they have really good research. But there's also some of this other study. Sleep improvement, there are lots of things you can do for sleep that don't involve meds. And I would really like to advocate that on a regular basis, especially with older adults. So you want to make sure people have light during the day. You want to minimize caffeine, especially after 12 noon. You want to keep people active. You don't want them to nap during the day. I mean, you can't sleep at night if you've been sleeping most of the day, in general. At nighttime, you want a quiet, dark room. You want not alarms that you might find in a hospital. You don't want to barge in. A really common thing in hospitals is they go around between midnight and 1 a.m. and wake everybody up and do vital signs. I mean, this is like, how can I make people more confused? Well, that's one way, right? So don't do it. There are reasons, there are reasons you might need to do it. There are conditions where you might need to do it. But the vast majority of cases, it's just practice. So in those cases, don't do it. You might want to consider offering earplugs, eye masks to people, some tranquil music. I would say you have to be careful if people are psychotic, right? If somebody's already hearing voices, if you give them earplugs, then the only thing they are going to hear are the voices, which are coming from their brain, and they're not going to have any sort of other information to help orient them. So that's not a good idea. If somebody who's paranoid, giving them a mask so they can't see is definitely not a good idea. You want to avoid things that are known to cause delirium. So that would be things like diphenhydramine or Benadryl, things like benzodiazepines. You could consider melatonin. There's some weak evidence and probably will be increasing evidence for that. You might want to consider an atypical antipsychotic if people are delirious in a dangerous way. And people who did a very similar sleep quality intervention, it turned out, that did help with delirium. Antipsychotics do help. It's the one medicine that's medicine group that has the best evidence for it. Antipsychotics are possibly overused in some circumstances, but delirium would not be one of those places where you want to avoid them at all costs. They're the best studied. Haloperidol or Haldol is studied. There's the most evidence for it. I just don't like to use it in people who are 70 and older. Hello, the highest risk group for delirium. Risperidone has some evidence. How do you want to use them? I'm a big fan of, if you know somebody has delirium, which means you've done the diagnosis, you've done the assessment, you're following the person for that problem. I'm a big fan of scheduled medicines rather than PRN, because PRN just means you're treating severe behaviors, PRN or as-needed medicine. What you really want to do is treat the delirium, and there's this dopamine excess in the brains of people who are delirious. So you want to avoid things that make it worse, benzodiazepines, anticholinergic meds. You want to help normalize sleep-wake cycle. You want people to be active during the day, frequent reorientation. You want to avoid dehydration. And you want to feed patients or people. We're not all patients. Some of us are just people. If people aren't eating or drinking, you don't just sit the stuff in front of them. You actually give them, you find out what they like to eat or drink. Give them smaller samples. People who are pacing a lot without trying to choke them, give them things that they can't choke on, but to take as they go, like tubes of yogurt or whatever. People who won't sit down, you have to figure out something else. But feeding people, encouraging them to eat is really, really important. So here's an algorithm. You want to find it. If you find it, you want to try and figure out what's causing it. By definition, delirium is caused by a medical or neurological condition. Delirium is never caused by a psychiatric condition, by definition. Consider drug withdrawal, right? A classic type of delirium is delirium tremens, which comes from alcohol withdrawal. That classic time to see that is 3 days after somebody moves somewhere where they don't have access to alcohol anymore. You want to make sure people aren't toxic on any medicines that they could become toxic on. You want to adjust doses for their kidneys and their liver. You want to consider antipsychotic medicines if they have delirium, and you want to follow them closely. So Mary Beth is somebody who I met in about 2006, I believe. She was 63 at the time. They called me up to see her because she had, quote, mental status changes, which is a great phrase that really doesn't mean anything. So I walked into the room, and she was talking to her husband, who, unbeknownst to her, wasn't actually in the room. And so then she started alternating, talking to me and her husband, like back and forth. And I really was the only other person in the room. Her attention was very impaired. She couldn't track. It was a clear case of delirium. She'd lost 20 pounds. She had a COPD, or a chronic obstructive pulmonary disease, emphysema flare. She was on some prednisone, which by itself disrupts the blood-brain barrier and can cause delirium. And then when you just looked at her home medicines, so the question wasn't why was Mary Beth delirious now. The question was, why wasn't Mary Beth delirious all the time? She was on amitriptyline for migraines. She was on Reglan for nausea and GI symptoms that she took every day. She was on Tylenol PM, which has diphenhydramine in it. She was on oxybutynin for urinary incontinence. And she was on lorazepam for anxiety. I mean, you know, it's just, if you want to impair somebody, you want your neighbor to look like they have delirium, this would be a nice cocktail to give them. I mean, I'm not recommending it, for the record. But, so what did I do? Well, I started her on scheduled risperidone. I got rid of the lorazepam. And if somebody's been taking that regularly, you actually need to taper it. You can't just stop it. I got rid of her Reglan. I recommended Compazine for nausea. Compazine is not, is slightly anticholinergic, but nothing like Reglan. Stopped her Tylenol PM. I started her on some low-dose mirtazapine or Remeron for sleep at the time. These days, I would probably have started her on melatonin. I wouldn't have done that. I lowered her amitriptyline. Now, I didn't stop it, and that's because I've stopped people who have severe migraines. I've stopped their amitriptyline in the past. I did it in a 90-year-old once, and it was really a disaster. There's nothing like having terrible migraines where, you know, you can't really focus and see things, and you're just vomiting, and you can't keep food down, and you just want to lay in a dark room with a blanket over you. It's just not a great quality of life. So I did that once, and I'm not going to do that again. So I lowered her amitriptyline, and I held the oxybutynin. She was in the hospital. She had a Foley catheter in, which she probably didn't need. But anyway, she certainly didn't need something for urinary incontinence. And then, because she was on this incredibly toxic dose of anticholinergic meds, I did a really unorthodox thing, which is I put her on a procholinergic medicine, which is rivastigmine or Exelon. That's a medicine that we use to treat dementia, but I put her on it for 48 hours just to sort of make the anticholinergic state go away quickly. I was about to go over to see her the next day, and I got a call, and they said, "Oh, you don't need to see her. We're going to discharge her. She's great." It's a miracle. And the husband said, "I have my wife back." And the good news is he was actually there saying it. So again, you know, this is just sort of a protocol. And it's, you know, pretty clear cut. It's kind of an inpatient protocol. One of the questions that I get asked is, if you put somebody on antipsychotics for this indication, when do you stop? And so talk about lack of evidence. There's zero evidence about this. So it's really a judgment call. So when I stop, it's probably going to be different than when most people stop, because I tend to get called about really severe cases. Sort of garden variety cases that people are able to take care of, I don't usually get a call about. But if somebody has had a past episode of delirium, there's probably something different about their brain putting them at high risk of delirium. So that's somebody who I would recommend considering treating with an antipsychotic if it helped them for about 2 weeks after you've seen full resolution of symptoms. It's just a recommendation. If somebody has dementia with behavior disturbance and also has a delirium, I would recommend a very slow taper off of over weeks rather than just abruptly stopping it. A lot of times what people call delirium really is just dementia with behavior disturbance in this group of people. Sometimes it's both, but sometimes there really isn't a delirium there. And so slow taper is better. And people who were posing a severe risk, you know, somebody who you had to call security or the police. I mean, you know, that can have a really bad outcome. So those are people I'd also recommend a slow taper. And these are 3 helpful websites. Vanderbilt ICU Delirium website is, it's been there for a long time. They keep it up relatively well, has lots of great tools, articles, and it's not all about the ICU, although they do focus on that. The VA has a quality improvement project and a delirium toolkit, which has some nice things. And then finally, Canada has great guidelines, one of which is in your packet on delirium. And they also, Ontario, Canada, is a province, and they have this website, Senior Friendly Hospitals, and it has a ton of great information, and it's one of my favorite websites. And it's talking about hospitals, but a lot of what they say can easily be adapted for other non-hospital environments. You know, the principles are the same. So those are websites, and so that brings us to time for a break. But if people have burning questions, I can take 1 or 2 questions, and then everybody can have a break. Not a single question. Okay. So the next 2 hours are going to be about dementia and dementia with behavior disturbance, and I will hopefully be highlighting the differences as we go, and if I don't, just put your hand up in the air and say, Dr. Nash, you're not doing it right, and I will take the feedback. All right, so 7-minute break. 5 minutes is too short, 10 minutes is too long, so come back a few minutes before 10.